I was also waiting for my car, and he was also in the corridor waiting for his car. He got some guests at home, so he brought one boy with him. I don't know who he is. I think he's a medical student. He was standing there and he asked, "Tataya, em nerchukunnaru kottaga meeru?" Then he just saw me there, and he with his smile always on his face, he said, "Of course, the style," he said. So he has learning every time, everywhere. Dr. Vijay Bhaskar, can you please make me the host? Enable me to share my screen to introduce Sanjeeva. So I'm not able to share my screen.
I'm doing it.
Okay.
You can start now, Kavita.
Yes. So okay. So he used to believe in learning forever. So this is the caption which I could find for him. So he was young till we lost him, and even in the end of on 28th January also, we had a bone club with him. So he was attending all our presentations. So he enjoyed all the presentations. So learning is forever for him. So now we have today with us one eminent speaker, Dr. Sanju Prasad. He's a chief interventional radiologist from Massachusetts General Hospital and professor of radiology at Harvard Medical School. Yesterday, I was listening to an interview of Sir where somebody asked him, "Can you name some of your students who have gone up to very great heights?" He said, "Yes, I have many abroad, and of course, few of them in India also, but who are all there abroad, they are doing very well." So that's the reason why we made this international webinars under KREST. One amongst those proud students are Sanjeeva Prasad. His area of interest is interventional oncology, pulmonary AVMs, and venous disease. He has more than 180 publications in multiple journals and more than 50 book chapters, and more than 1,000 scientific abstracts, and then more than 100 presentations. So with this short introduction about Sanjeeva from his 59 pages CV, I'll ask him to go ahead with his presentation. Dr. Sanjeeva.
Thank you, Kavita. Thank you very much for inviting me to speak at the KREST Zoom meetings. Most of you don't know about me. So when I joined medical school in Kurnool in '88, we already knew about NIMS because of Pocketal, sir. It was always amazing to hear MRI came to NIMS, and MRI can diagnose anything in the body. So that was the inspiration for us to actually get into radiology. So first I got into DMRD in NIMS, and within a day I resigned because many people felt DMRD is not a good thing for long term. Then I got into JIPMER MD radiology. I wasn't very happy there, mainly because the education was not great. Dr. Kakala sir came to Pondicherry for a meeting. So I met with him and asked him, "Hey, can I come to Nizam's? Because I'm really feeling unhappy here and I'm not learning anything." He said, "You apply again." So I applied, and Dr. Subrahman Madam took me as one of residents there. So then Kakala sir rejoined the NIMS at age 97. I was very fortunate to spend time with him from 97 to 1999. So 2 years of association with sir. And then after that, I moved on to Coimbatore and then 2 years. I wish I had more time to spend with him, but within a short period of time, I learned a lot from him. As you all know, he's a great radiologist, but somebody mentioned he's the person whom we can admire always. It's not just about radiology. It is about, as a person, what you can bring up as a big hospitality and teacher and good person, helping others to grow. So these are good qualities we can all learn and inspire. The one thing I always stuck to me is what he said, learning is fun. So I never felt that somebody could say that. And I really felt it touched my heart even now that learning can be fun, learning is fun. And it becomes fun when the teacher is good, the subject is taught well, and the student is interested. So all these things should match. And these things match very well when we love it. So we have to love the subject, we have to love what we do, then everything is fun for us. So with that, my interaction with Dr. Kalva, and I would start my lecture. So my topic is venous compression syndromes. Because most of the participants are diagnostic radiologists, I will focus on diagnostic imaging of venous compression syndromes and briefly discuss about interventional aspects of venous compression syndromes. So these are my disclosures. So the objectives of this lecture are to review the pathophysiology, etiology, symptoms, imaging findings, and management of common venous compression syndromes. Specifically, we will discuss only 4 topics today. One is iliac vein compression syndrome, also known as May-Turner syndrome, Nutcracker syndrome, thoracic outlet syndrome, and Pocketal venous entrapment syndrome. All the venous compression syndromes are characterized by these 4 characteristics. Number 1, this compression is dynamic. It is not static compression by a lymph node or a mass or a pregnant uterus. It is a dynamic compression and by external structures such as arteries, ligaments, bones. And these extensive compression will be repetitive and dynamic. So this repetitive injury to the venous system will cause endothelial injury in the vein. Whenever there is endothelium injury, it causes thrombosis. Initially small thrombus, which leads to recanalization, and over time it's scarring. And over a long period of time, this scarred vein will lead to progressive venous hypertension. So all the syndromes characterized by clinically, number 1 is they present with DVT because venous injury leads to DVT. Chronic venous obstruction leads to venous hypertension. Whenever there is venous hypertension, there is a valve dysfunction and varicose vein formation. And then there is skin discoloration if it is extremities, or if it is other organs, is corresponding to organ diseases. And there's a collateral formation to bypass obstruction. So if you remember these 3 things, DVT, collateralization, venous hypertension, these are characteristics of these diseases. So syndrome is referred to when the patient's present with symptoms, such as DVT, or pain, or varicose veins, or fatigue, those things, or hematuria in the case of Nutcracker syndrome. A word, a phenomenon, or anatomy is used, and the patient has no symptoms, but the imaging shows these findings. So let us talk about May-Turner syndrome. So May-Turner syndrome refers to compression of left common iliac vein by the overlying right common iliac artery against the spine. And this leads to a repetitive compression of the vein here and the venous injury and DVT. So when the patient presents with DVT, it is called May-Turner syndrome. If the patient doesn't have DVT, but you saw this picture on an MRI or on a CT, then you call it as May-Turner anatomy or May-Turner phenomena. So this condition was described long ago by May and Turner while reviewing the autopsy specimens. In patients who have this compression, there's a repetitive compression of the artery onto the vein leads to venous spur formation. This spur is because of repetitive thrombus, endothelial injury, and fibrous tissue formation at this location. So depending on the stage of the disease, whether it's early compression or long in the process of the disease, you might see small spurs. These spurs may not be visible on venography or MRI or on CT, but they will be visible with endovascular ultrasound imaging. And as these spurs become bigger and bigger, the thrombus will be seen in all imaging modalities. Recanalization leads to scar formation or this web-like architecture inside the venous lumen. Some of the lumens are big, some are small, depending on how the recanalization has occurred. Depending on the level of occlusion, CT venography classified them as a focal occlusion, called type 1, a long segment narrowing of the vein, or cord-like narrowing of the vein. There isn't a big significance in whether this type 1 or type 3, but the difficulty in recanalization increases between type 1 versus type 3 because it is much harder to recanalize this vein, whereas a focal short segment occlusion of type 1 disease. but the symptoms are usually the same. In general, women tend to be more commonly affected than men, and women tend to get the disease at a younger age. There is a significant correlation with the start of oral contraceptive pills in young women. There's one paper that suggested that patients who have Methanol syndrome, if they start on oral contraceptive pills, the risk of DVT doubles in those patients. Patients may present with acute or recurrent DVT, which happens to be equal incidence in both men and women. Of note, patients who present with isolated left leg DVT have between 18% to 49% incidence of Methanol syndrome in those patients. PE tends to be more common in women than men. Chronic venous disease appears to be much more common in men than women, mainly because these patients present late in the disease, whereas women present early in the disease with DVT, so they will get treatment. Whereas men, they don't present the DVT or PE, so they only present late in the disease process with the chronic venous disease in terms of leg swelling, pain, varicose veins, venous dermatitis, or chronic venous ulcer in the foot. So how do you diagnose this one? The first and foremost imaging modality we use is ultrasound imaging. Thanks to Dr. Subbulakshmi Murthy, who taught us Doppler quite well. As you could see on the right side here, right common femoral vein demonstrates normal respiratory variations of the venous flow. On the left side, there's a flattening of the vein, a Doppler signal without any respiratory variations, suggesting that the compression is proximal in the iliac venous system. It is not in the IVC compression because right common femoral vein is showing normal respiratory physicity. So this can occur in any other disease condition, not just necessarily Methanol syndrome. It can occur with lymph node compression. Anything that disrupts the respiratory variations to transmit to femoral vein, this appearance will be seen. You may also see DVT or sometimes collateral veins in the anterior abdominal wall draining into the common femoral vein. CT is much more effective in diagnosing this condition. As you could see here, the compression of the left common femoral vein by the right common iliac artery. Not only that you will see compression, you will also see collateral veins, especially in the ascending lumbar vein, which runs parallel or by the left side of the spine or in the pelvis. You may also see thrombosis in the iliac or femoral venous segments. One thing you must note that the venous compression is variable. As much as 65% luminal compression is seen in normal adults. So you should not just diagnose Methanol syndrome just because you see a compression. This is a patient who had an MRI on a separate date and a CT performed a different date. So here you can see an MRI, we may diagnose this as a Methanol because left common iliac vein is compressed by the right common iliac artery and the lumen is narrowed by more than 50% here. However, the same patient who had a different date, here there's no compression. So what happened here? So venous compression is highly dependent on the blood volume. So if MRI was done when the patient is dehydrated, he had water in the morning and he got the MRI done at 12 o'clock in the afternoon, he had nothing to eat or drink for 6 hours. So this is what you see. Here, the CT scan was performed. He had a good lunch and had a good water. And then you saw the scan. Then there's good compression. There's no compression of the iliac venous system. So the blood volume has significant effect on the venous compression. So you should not diagnose venous compression just because you see compression. Then how do you make a diagnosis? Number one, if the clinical diagnosis is venous compression, you must do the scan with a good hydration, not an empty stomach, not dehydrating the patient for 4 to 6 hours. Then the most important thing is if the venous compression is physiologically significant, you will see venous collaterals. We will discuss that in the next slides. So here you can see, not only you can see venous compression, but you also see venous collaterals. If you do see venous collaterals in the ascending lumbar vein or in the pelvis, then this compression is physiologically significant. If this compression is present, but if you don't see collaterals, this compression is most likely not physiologically significant. So another technique that is very well useful in diagnosing hemodynamically significant venous compression is the time of flight technique. I vowed Dr. Jaganmohan Reddy to teach me how a time of flight MRI is done. In 1997, on my first MRI posting, he took time to explain to me how the time of flight technique actually works. So people who have not done this well, so whenever you want to image blood vessels, you want to saturate the blood that is coming into the field so that you won't see the signal. So if you want to see the veins, you want to saturate the arterial blood so that you don't have the signal from the arterial blood. So if you want to scan this level with a slice, so you do a 2D slice technique here, you get a slice here, but you put a saturation band from here to all the way up here. So all the arterial blood that is coming in is saturated, but the venous blood that is coming inferior to superior is not saturated. So these protons can give signal at this slice and they can catch the signal. So when this saturation band and the slice will move cranially as you start gaining the signal from the venous system. So saturation band moves from this to here as you move your acquisition slice. So what is important, whatever the blood that is going from the caudal to cranial end will be seen on the time of flight sequence to image the veins in the pelvic and femoral venous system. If the iliac venous compression is physiologically significant, meaning this compression is really severe and blood cannot go, where will the blood go? Blood will go through the internal iliac vein, reversal of flow, and cross the pelvic collaterals, and then go into the right common iliac vein and go back to the common iliac and to the IVC. That means this iliac vein will have reversal of flow. So the saturation band will saturate the blood here too. So if you do see this infernal iliac vein, this compression is not significant. If you don't see this left internal iliac vein, then this compression is significant. So here you can see in this particular patient, you can see absolutely no signal coming from the left common iliac vein because of the compression. But this compression is not physiologically significant because there is normal opacification of bilateral internal iliac veins on the time of flight technique. Whereas in this patient, there is compression, there's absence of signal here, and also that the left internal iliac vein has no signal because of reversal of flow. This compression is physiologically significant. So even at the time now, we have all the new techniques for MRI, true phase and contrast enhanced, we always obtain time of flight 2D sequence for venous imaging, especially for Methanol Syndrome, to assess for reversal of flow in the left internal iliac vein. You may also see the ascending lumbar vein. Normally, the ascending lumbar vein drains cranial to caudal in normal patients. So you will not see in a 2D time of flight technique in normal patients. But if there is a compression here significant, then the blood will go towards the cranium on this vein to drain into the renal venous system and lumbar venous system. So you might see ascending lumbar vein if the compression is physiologically significant on this patient. One thing we must remember is the signal may be absent because this vein is thrombosed. That is why you must get a contrast enhanced imaging to rule out whether there is the flow is reversed or the vein is thrombosed. I hope I was clear in this explanation. Again, you might see venous thrombosis in the femoral venous system. You might see anterior-abdominal wall collaterals like here if you do see those things. The intravascular ultrasound is extremely useful for interventional radiologists. Number one, it can detect spurs. So you can see these are the spurs, these tiny hyperechoic structures inside the wall or inside the lumen attached to the wall. So these are the microthrombi or microscars that formed in the wall because of chronic repetitive injury to the venous endothelium. You might also see chronic thrombosis or acute thrombosis. In patients who have a recanalized thrombus, you'll be able to see which are the largest channels. You might have passed the wire through a small channel, which will be harder to recanalize. So you may want to see what are the other channels look like. If you do see a large channel with IVUS, then you might want to recanalize through that large channel when you place a stent. You can measure the length of the occlusion accurately with intravascular ultrasound. You may also be able to identify the normal diameter of the vein, peripheral or proximal to the occlusion. And stent also guides us to place the stent. The IVUS also guides us to place the stent accurately. And also post-stent imaging is useful to assess intimate hyperplasia that might occur inside the stent. Venonography is very useful. So first thing, as I mentioned to you before, here you can see the catheter coming from the neck. The catheter tip is placed in the external iliac vein. Here we are injecting the contrast in the external iliac vein. What should happen in a normal patient? The contrast would go into the common iliac vein and goes to the IVC. But in this particular patient, because there is severe compression by the right common iliac artery on the left common iliac vein, this is physiologically significant. Blood is going into the left internal iliac vein, cross pelvic collaters in the right internal iliac vein, and back into the right common iliac vein into the IVC. Now you can also see reversal of flow in the ascending lumbar vein. Normally, ascending lumbar vein drains into the common iliac vein. The flow is always craniocaudal, but because of compression, the blood is going in the opposite direction here. Another patient, you can see cross pelvic collaters, multiple presacral collaters, and also enlarged ascending lumbar vein here. Another patient, cross pelvic collaters, again, multiple recanalized channels on the prior thrombus inside the left common iliac vein. Not only that, you'll be able to see the physiological effect through the venous compression. Venography allows us to also measure pressures. If you measure pressures in the common femoral vein here and the pressure in the IVC, normally there should be no gradient. If the gradient is more than 2 or more than 3 after exercise, that is physiologically significant and warrants treatment. You can see webs and channels, as you could see in this particular patient. So how do you treat these patients? If the patient is asymptomatic and the imaging shows venous compression, there's no treatment required. Normal aerobic exercise like walking, running, jumping would help improve the venous flow. Patients with mild symptoms can be treated with the compression stockings. Patients who present with acute DVT requires treatment with anticoagulation, thrombolysis, and relieving obstruction through angioplasty and stent placement. Chronic occlusion may present with chronic pericosities or chronic venous hypertension. Those patients may benefit from recanalization of the occluded iliac venous system and stent placement and long-term anticoagulation. Veno-veno bypasses are not very effective. They tend to occur within a year, the patency of around 40 to 80%. All the stents that placed for iliac vein compression needs management. They require long-term anticoagulation, long-term anticoagulants. We tend to use large diameter self-expanding stents. Initially, we used to use wall stents. Now there are dedicated iliac venous stents that came from Bard, Medtronic, and Boston Scientific. These are called Vichy, Vinova, and Abri stents. They're specifically designed for iliac venous compression. They have gone around very prospective year-long trials and have shown long-term safety, at least for a year time, and good patency of the stents. So right now, we are choosing one of these 3 stents rather than wall stents. So it's a patient who presented with acute left lower extremity DVT, as you could see, filling defect on the venography in the femoral venous system and a common femoral iliac vein all the way up to the junction on the iliac venous system here. So we used a rheolytic thrombectomy using angiojet device, and we did thrombolysis, angioplasty, the obstruction. Subsequently, you can see a nice opacification of patent lumen here. And at the end, we did place a stent because this compression is dynamic. Angioplasty will not work in these patients. Angioplasty is not going to treat extrinsic compression. Extrinsic compression will only be treated with surgical decompression or with stent placement in cases where it's safe to use a stent. So in this case, it is safe to use stent. So here we can place a stent here. So how do stents behave? Overall, there is 99% efficacy in primary patency, 100% primary assisted patency, and secondary patency around 96% at 3 years. So stents do extremely well in Methanol syndrome, provided you place a proper stent, long-term anticoagulation, and antiplatelets, and proper follow-up in these patients. So what are the complications of stent placement? Stents can get crushed, especially stents that are made of nitinol stents, unless they're specifically made for iliac venous system. So these are originally arterial stents, like life stents, which are not designed for the venous system. They tend to be compressed by the artery. The new stents are not like this. You may also see intima hyperplasia that can induce recurrent thrombosis. Overall, there's 88% stent occlusion rate at 1 year with iliac venous stenting. You can treat them with thrombolysis and angioplasty on relining of the stent if required. There are some variations of Methanol syndrome. So normally, Methanol syndrome refers to compression of the left common iliac vein by the right common iliac artery, but sometimes the abnormal course of the left common iliac vein, as in this case, where it is going between the iliopsoas muscle and the sacrum, that's where the compression is happening. In this case, there's a right-sided iliac venous compression, where the right common iliac vein is compressed by the right common iliac artery. Some people call it right May Turner. It may also occur in patients who have itoiliac aneurysmal disease, in which case the iliac artery aneurysm compresses the right common iliac vein. Whatever the compression is, it is extrinsic and dynamic compression, a repetitive injury venous endothelium, the symptoms are same, treatment is the same in those patients. So in summary, Methanol syndrome refers to compression of left common iliac vein by right common iliac artery, results in DVT, venous hypertension, and varicose veins, treated by thrombolysis and stenting, followed by long-term anticoagulation. Stent patency is around 90% at 2 years. Any questions so far? Okay, we will move on to the next topic. That's a Nutcracker syndrome. Nutcracker syndrome refers to compression of left renal vein between the aorta and the superior mesenteric vein. That results in venous hypertension in the left renal vein peripheral to the compression here. And this increased venous hypertension will lead to venous hypertension inside the kidney that can manifest as pain or hematuria or orthostatic proteinuria. Most often, the left renal vein is decompressed by the gonadal vein because of reflux that develops at the venous valve here. Because increased pressure, this pressure exerts more pressure on the venous wall, the valve fails, and the left renal vein decompresses into the left gonadal vein. In men, it is testicular vein that leads to varicocele. In women, because the ovarian vein communicates with the pelvic veins, that forms as a pelvic venous congestion. Rarely, an anatomical variant where the left renal vein may be present behind the aorta between the spine and the aorta, that may be where it is compressed. In those cases, it's called retroactive left renal vein, and that is also can cause renal vein compression and findings similar to Nutcracker syndrome in those patients. So it's more common in young adults, slightly more common in women. Patients present with the left flank pain, gross or microscopic hematuria or orthostatic proteinuria. Women can present with pelvic pain because of pelvic venous congestion and vulval varicosities. They may also have dyspareunia. Men will present with varicocele, as I mentioned before. So how do you diagnose? Again, ultrasound is effective in diagnosing this condition. As you could see in this ultrasound, you can see severe compression of the left renal vein at the itomesenteric segment, that the distal dilatation of the left renal vein because of the compression. You may also see thrombus formation because of slow flow in that segment. You may also assess the Doppler effect in those areas. You should assess Doppler velocities at the compression site and the peripheral site. If the ratio between the two is more than 3 when the patient is lying down, or more than 5 when the patient is standing up, that is considered significant. And or if the peak velocity at this compression site is more than 100, that is also considered significant. And overall, these two findings have a sensitivity of 78%, but highest specificity 100% just by using ultrasound. CT is very accurate in identifying the compression. As you could see here, very nice, significant compression of the left renal vein between the aorta and the superior mesenteric artery. On the sagittal reformatory picture, you may also see the compression very nicely. In addition to subjective evaluation of the compression, there are some objective measurements that help you to diagnose this one. Number one, you measure the diameter of the vein at the compressed site versus the peripheral left renal vein. If this ratio is more than 4.9, that is considered significant. Then you also measure this angle at the compression site. It's also called a beak angle. If the beak angle is less than 32 degrees, that is considered significant. You also measure the angle between superior mesenteric artery and the aorta. If it is less than 41, that is also considered significant. So among all, this beak sign, the presence of beak appearance is more significant. So in addition, as I said before, whenever there is venous compression, body tries to develop some collaterals. Presence of collaterals indicates that compression is physiologically significant. So identifying the collaterals is much, much more significant than measuring angles or subjective evaluation of the compression. So as you could see here, among all various anatomical findings, the beak sign is considered the most sensitive and specific. Again, MRI will show same findings as CT, venous compression between the aorta and the superior mesenteric artery, and the reflux in the gonadal vein and pelvic venous congestion. So angiography again demonstrates here the contrast is injected in the left renal vein beyond the crossing over a superior mesenteric artery. You can see nice indentation on the left renal vein by the superior mesenteric artery. Also, you see reflux or contrast in the left gonadal vein. So these are the characteristic findings on venography. You can also measure pressures between the renal vein peripherally and also in the IVC. This gradient, if it is more than 3, that is also considered physiologically significant. The patient is asymptomatic, there is no treatment required. Most of these patients resolve spontaneously. If the patient is symptomatic, then you may want to treat them according to symptoms. If the symptoms are predominantly pelvic venous congestion, then gonadal vein embolization may be considered. If the patient has a varicocele, you may embolize the left gonadal vein in those patients, or surgical treatment of the varicocele can be considered. The patient mainly presents with renal left flank pain, hematuria, orthostatic proteinuria, then one must consider other options. One is called renal vein stent placement. Most of us do not prefer doing so, and most of us do prefer sending the patient to surgery, where they may do transposition of renal vein or transposition of SMA. They may also do gonadocaval bypass, or rarely some surgeons do autotransplantation of the kidney. So this is the case which I had, where the patient predominantly presented with pelvic venous congestion. So we went ahead and embolized the pelvic vein, the left gonadal vein after symptoms resolved, and we did not treat the left renal vein compression. So this is a case from the BJR where this radiographics. Here, this patient presented with orthostatic proteinuria and hematuria. In this patient, the gradient was more than 6 between the renal vein and the IVC. They went ahead and treated with a stent placement, and the stent was effective in reducing the pressure and also decreasing the venous congestion here in the kidney. One of the problems, stent placement in this segment is very short. Stents can migrate into the IVC and into the heart. And again, the compression is repetitive, so there is always a risk that stents can crush in this area. In general, most of us prefer a surgical treatment rather than a stent placement in those veins. Again, summary. Nutcracker syndrome refers to compression of left renal vein between superior mesenteric artery and the aorta, leads to left renal vein hypertension and gonadal vein varices. Patient may present with hematuria, flank pain, pelvic congestion syndrome, or left varicocele. Patients are treated with conservatively or gonadal vein embolization or surgical therapies. Any questions? So the next topic is thoracic outlet syndrome. This refers to compression of subclavian vein between the clavicle and the first rib. This picture depicts the anatomy of thoracic outlet. Unlike subclavian artery and the brachial plexus that run between the scalenus muscles, subclavian vein runs between the anterior scalenus muscle and the costocoracoid ligament. So this space is the area where the subclavian vein enters the thorax. So this subclavian vein is bounded by posteriorly by the anterior scalenus muscle, anteriorly by the costocoracoid ligament, and inferiorly by the first rib, superiorly by the subclavius muscle and the clavicle. So any problem occurring in any of these surrounding structures can lead to injury to the subclavian vein. But these structures are very important in the movement of the hand above the clavicle level. So if you want to move your arm above, this is where the movement of this costocoracoid ligament area actually moves a lot here. So people who do repetitive movement of the hand above the level of the clavicular level, like horse riders or cricket bowlers or softball players, they tend to get subclavian venous injury. So this is also called effort syndrome because effort leads to venous compression. Other anatomical causes include cervical rib, hypertrophy of the scalenus muscle here, or subclavius muscle, or prior fracture of the clavicle or the first rib, or tumors of the clavicle or the first rib that decrease the space here and cause compression of the subclavian vein. This tends to be bilateral in 21% of the patients. So it involves the dominant arm of patients who are physically active, such as horse riders, softball players, cricket bowlers, etc. Symptoms are provoked by excessive overhead activity. The more you do it, the more likely to get injuries to the subclavian vein, also known as effort thrombosis, as I said. It's more common in men than women. Symptoms are usually unilateral arm pain and swelling because of DVT, hand cyanosis, enlarged shoulder and chest wall collaterals when the disease is chronic. CT and ultrasound both will demonstrate upper extremity DVT. CT in particular can demonstrate the cervical rib or fractures or tumors of the first rib and clavicles, and also the venous compression of the subclavian vein. You may also do dynamic imaging on CT, acquiring two times, one in neutral position, one the hand up above the head, and see the compression is present or not. As I said, it's bilateral in 21%. You must always evaluate other side to look for venous compression on the other side too. Similarly, MR venography also demonstrates the same findings, DVT, collaterals, or venous compression. Here, this picture demonstrates a direct MR venography, where here the neutral position, there is no compression, but when the hand is positioned above the head level, you can see severe compression of the left subclavian vein at the level of the thoracic inlet. This is the venography picture, which demonstrates thrombosis of this axillary and brachial venous system, and also the compression of the subclavian between the clavicle and the fistula. Again, fluoroscopy may also demonstrate anatomical abnormalities such as fracture of the clavicle or the tumors of the clavicle or the fistula. The patient presents with acute DVT. Treatment is usually by stockings, anticoagulation, and thrombolysis. Chronic injury to subclavian vein present with venous hypertension may be treated with stockings alone and anticoagulation. Sometimes we do treat them with long-term anticoagulation followed by venous recanalization, first-step resection. The definitive treatment is first-step resection in those patients. So there's a patient who presents acute DVT. Here you can see the occlusion of the axillary venous subclavian system. This is the collateral vein. Here you could see recanalizing through the or perfusing through the collaterals in the neck, and also the brachiocephalic vein here. So here we went through the occlusion, we did thrombolysis, and you can see we recanalized the entire subclavian. When there's still some amount of thrombus left over, then we send the patient to the surgeon. Surgeon did the first step resection, and this is the post-step resection. Still there is compression, or this is the patient actually. So you can see the post-step resection, there is a nice recanalization of the patient. So if the patient has recurrent thrombosis after rib resection, you can go ahead to angioplasty again. If required, you can also put the stent after rib resection. You should never place a stent when the rib is not resected, because two bony structure will crush the stent. Stent should not be placed when the rib is not resected. So overall, thoracic outlet syndrome is caused by subclavian vein compression at the costoclavicular triangle, common in dominant arm, provoked by excessive overhead activity, diagnosed by ultrasound, CT, and MRI. Dynamic imaging is helpful to detect asymptomatic occlusion. Treatment is thrombolysis followed by the first step resection. So next is a pocketal venous entrapment syndrome. This refers to compression of the pocketal vein in the pocketal fossa by the muscles or ligaments. These are 6 types. Type 1 and 4 refers to arterial entrapment. Type 5 is similar to the arterial entrapment, but here the pocketal vein is entrapped, where there is abnormal insertion of middle head of gastrocnemius or aberrant course of the pocketal vessels, or compression by the ligament, fibrous band, or the popliteus muscle. So these are anatomical abnormality. Type 6 is called functional abnormality, where the calf muscle hypertrophy can cause compression of the popliteal vein. So this is very common in men, 9 times compared to women, one times. Patient presents with a lower extremity swelling, popliteal vein DVT, isolated reflux in the popliteal vein, or recurrent varicosities after treatment. So how can you diagnose? Again, ultrasound is very helpful to diagnose this one. Here you can see the normal veins, the popliteal veins. Whenever there's a knee extension, there's complete compression of the popliteal venous system. So active plantar flexion or the dorsiflexion of the ankle with full extension of the knee using footboard will assess the venous compression. So this dynamic maneuver is helpful to diagnose the popliteal venous entrapment. So on MRI, you can assess a functional compression here. You can see MR venography here. Here venography demonstrates the same abnormal compression of the venous system on provocative maneuvers. The compression can be present above the knee or at the level of the knee or below the knee, depending on the course of the vein between the middle head of gastrocnemius or the popliteus venous system, popliteus muscle, that is how it is inserted in the area. So before treating this patient, people always do venous pressure measurements. So in a normal patient, whenever you do, for example, dorsal venous pressure and the popliteal venous pressure, the pressures are usually low in the popliteal vein. If you do exercise, the popliteal venous pressure increases. In a normal patient, after exercise is completed, the pressure comes back. But in patients with popliteal venous entrapment, the venous pressure continues to be elevated even after exercise. So this is considered abnormal, and those are the patients who require surgical therapy. So persistent elevation of the venous pressure hundreds and seconds after sustained exercise is the most important findings functionally to diagnose venous entrapment syndrome. You can also see increase in the popliteal vein pressure with any extension, which we all know at ultrasound examination. An increase of more than 44 is considered significant in those patients. So in asymptomatic patients, no treatment is required. In symptomatic patients, surgical decompression, where the resection of middle head gastrocnemius or removal of the ligament or popliteus muscle is considered. If the venous system is aneurysmal or thrombosed or stenotic, one can also perform veno-veno bypass in that segment. So this is the end of the lecture. Thank you very much for giving me the opportunity to speak at the KREST symposium. If you have any questions, I'm happy to take the questions. I will stop sharing.
Sanjeeva, how do you measure the popliteal vein pressures? Is it an invasive technique?
Yes, you just put a small angiocath into the popliteal vein and connect to a manometer.
And then Dr. Rajgopal had a question for you. How do you determine the stent size in left renal vein stenting? How do you determine the size of the stent?
So that's a good question. So you use the peripheral venous segment diameter as the baseline. You always oversize the stents in these areas. As I said, I have never done a single left renal vein stent. We do not do them. We send all those patients to surgeons. If you do decide to place the stent, it is in general, whenever you want to stent a venous system, it is always preferable to use a self-expanding stent. But in the left renal venous system, it is very, very hard to place a very small, short segment, self-expanding stent. That's the only area probably I would use a balloon expandable stent, and I would over-dilate the stent so it stays there.
Yeah, that was an excellent presentation, Sanjeeva. This is Dr. Ram here, Dr.
Hi,
Ramoni. Yeah. Just wanted to ask you the so-called thoracic outlet or Paget Schrotters, these kind of complex venous injuries, as you mentioned, with which are associated with effort. Do they also have some injury to the thoracic duct where it opens, and do they have some kind of injury there?
That's a good question. I don't know the answer. So as you know, thoracic duct enters the left subclavian vein at the junction with the jugular vein and subclavian vein. So usually it is just above the level of the compression site. So I have never seen a patient who had ascites or lower extremity edema because of thoracic outlet compression or thoracic duct injury there. But recently in the last FSIR meeting, Dr. Maxim Itkin presented 4 cases of thoracic duct stenosis at the joining of the subclavian vein. None of these patients had thoracic outlet syndrome, and he did angioplasty of thoracic duct to relieve the ascites and lower extremity edema. So that entity exists, but I don't know whether they're associated with thoracic outlet syndrome.
I think more than the ascites, they may be associated with the chylothorax, right?
Yep.
Thank you. Thank you very much.
Sanjeev, this is Ravi Shankar. Just want to ask you, like, how frequently do you see like Methanol patients in your practice? Like, do you see like once a month, or like, I know like you are a high referral center. What is the practice volume or patterns?
That's a good question. It all depends on the practice pattern. My division treats a lot of venous disease. So when you're treating, we treat probably around 100 to 200 venous disease patients a month. So that's a very high volume. When you have such a high volume, we do almost every week, once or twice venous stenting. And patients who fail varicose vein treatment, we tend to evaluate. Patients who have pelvic venous congestion not responding to treatment, we also tend to evaluate for the Methanol syndrome. So our positive rate is quite high. And second thing is, patients who have isolated left lower extremity DVT are referred to IR division here to look for Methanol syndrome. So there is a selection bias for us. So we do get specifically those patients who may have this condition. The third is, our hospital scans every young patient who presents with stroke or TIA, who had a PFO and echo. All these patients get MRI of the pelvis to detect for pelvic and lower extremity thrombi. Those patients have 5% incidence of Methanor's anatomy.
Sorry, repeat the last one.
So patients who are young, less than 50 years of age, who present with stroke and do not have a carotid artery disease, they get an echocardiography. If echo shows PFO, and all those patients are worked up for paradoxical embolus, and those patients get pelvic MRV and lower extremity ultrasound study for DVT. And in those patients, we have seen 5% incidence of Methanol syndrome. So now we are treating those patients with at least with the IVUS to assess microthrombi in the iliac venous system, which could be responsible for this stroke in those patients. So we are skewed in terms that our referral pattern is different, so we do get quite a number of patients. If you take a general public, it's not that common.
I think the last one, I do see about stroke, that's interesting that you are evaluating them for venous disease. Good to know. Thank you.
It is one of my cardiologists put his name for this. Ignatius disease, his name is Ignatius, he put his name on it.
Sanjay, there are couple of questions in the chat box. One from Dr. Divyesh. When do you recommend rib resection in case of central venous stenosis in AV fistula?
That's a fantastic question. I'm glad somebody asked that question. We go through this every day. We have a very high dialysis practice. We do 5 to 10 fistulograms or graftograms every day. And at least I can say 20 to 25% of these patients have venous compression of the subclavian vein in that area. So we do recommend rib resection in these patients, but none of the surgeons want to operate on these patients, mainly because they're very poor surgical candidates. All of them are ESRDs, ASA3, ASA4 disease. They can't operate. So I can count on fingers how many people actually got rib resection. But this may be something we want to work on. We are suggesting that can we do cryoablation of the first rib so that the compression can be relieved in these patients instead of resection. So we are looking at minimally invasive options for these patients to soften the bone so the compression can be decreased. We have not yet done it, but something that we can think of. And the next question I see from
Ashish, yeah.
With MTS and reflux at the junction of SFJ and SPJ, what would you treat first? I always treat the varicose veins first. If it fails, then I go to MTS because I don't know whether MTS is significant in this patient or not. So instead of jumping to stent the iliac vein, first I treat the a very great saphenous vein with the laser or RFIR Venocil, and then decide if the veins recur, then I'll go after the MTS. I'm very conservative to treat MTS unless there is a DVT. Without DVT, I tend to not to treat those patients.
Any comments from others? Dr. Jagan sir, any comments on MR role in diagnosing these situations, your personal experience? Dr. L.T. Kishore, Dr. Jagan Mohan Reddy, any others?
It's a fantastic lecture, and thank you very much, Dr. Sanju Prasad.
There are none. Dr. Vijayabhaskar for the concluding remarks.
Thanks, Ishwar. Thank you very much, Sanjeeva. That was a fantastic presentation. We wish to have much more of these whenever you are free, and enlighten the students here with your great knowledge of interventional radiology, especially the vascular compression syndromes and other things. Really happy that you have taken part in this program today. Next week, I think there is a May 7th, there's a so Sirisha is going to talk about temporal evolution of metastatic disease. So we'll put up that topic and the presentation. The template we'll put up very soon. Thank everyone for having come and visited this KREST international webinars, which are very close to our heart now. We started it for the sake of SIR. We'll continue it for the sake of SIR as long as we can. And we wish to take help from all of you and active participation from all of you. It's not only international webinars. Let us do all teaching programs, whatever is possible. Kishore sir, You said technicians teaching. We'll do on web. No problem. Now situations are not conducive for a offline program. We can do online program. You plan, we are there. As simple as that. KREST is there for whatever you plan. We'll make SIR's idea and SIR's future, what he looked at, we'll try to make it possible. Thank you very much.
That is the greatest tribute we can pay to sir.
Yes, sir. Yes, sir. So this is what we request from all of you, sir. Thank you very much, and we'll call it a day today, sir. Thank you, Masadan Ragar.
Thank you very much, Dr. Vijay Bhaskar and Dr. Kavita and Dr. Mr. Chandra.
Bye, Sanjeev. Thank you.
Everybody,
Thank you. Thank you, Sanjeev. Thank you.
that's beautiful.
Thank you.
Thank you, sir.